So Claire and Wayne bought us some time, so this is now a 20-minute presentation. And I'm last, you can't do anything about it. No, I joke. I do want to say a couple of things first though. Those of us that are involved in the presentations know how much work Marty and his team put in behind the scenes. And I think actually, you know, the kind of way he structured it and all the stuff going around it, big hats off to Marty because it's a completely different conference. And I think we should show our appreciation. Wayne alluded to being nervous when he stood up here, and I have to tell you, and I've done a couple of presentations over the years, this has definitely taken me out of my comfort zone without a shadow of a doubt, mate. So don't worry about it, which is why I think, Jack, did I get it right? You're a second-year podiatry student. Yeah. Was that right? Yeah. Mate, I'm telling you, hats off. I wouldn't have had the balls to do that then, and the quality you did. So, Emma, that is 10% onto his degree, right? Okay, but we're taking 10% off whoever did this title slide and gave me AIDS. All right? Having a laugh, aren't you? My first slide would normally be a declaration, right? But as we only allowed 10 slides, I weren't going to waste a slide on it. But I need to tell you that I'm a non-exec director of Run3D, which is the company that supplies 3D equipment to clinical practice. So you need to know that before I do the presentation. So I think we can accept from the literature the root and all theory of subtalar neutral and that the foot should function around this magical position is at best flawed. No one's been able to describe how we optimise function, more how we manage pathology. Niggs talked about the preferred motion pathway, which is that unique set of function each individual possesses to minimise energy expenditure. And if there's noise around that deviates you away from that preferred movement pathway, then you have the potential to increase energy expenditure and, excuse me, and perhaps injury. And we're all aware of the concepts in terms of muscle for power generation, initiation motion and control. But in recent years, more attention has been paid to muscle vibration and how it attenuates load. It would appear that the structures proximal to the knee are primarily responsible for attenuating vibration and therefore dampening load. So as a result, during function, they become gradually stiffer and therefore will be affected by and will affect the preferred movement pathway. Wayne alluded to every individual will have a degree of asymmetry, but that degree of asymmetry and their method to control it will determine their function, their potential for injury. Similarly, there will be asymmetry between individuals. And we have to accept that. So trying to get every individual to function in a symmetrical pathway is rather like trying to get these two waterfalls to flow in the same direction. Whilst we may be able to demonstrate barriers to function and be able to modify them, we have to accept the limitations. So as a result, perhaps what we need to do is to modify the factors that we can so that we optimise that preferred movement pathway or potentially change that so that we change the preferred movement pathway. But our ability to do that will be dependent upon, do you know what? You could tell, the people that have seen me lecture before, I'm like going, blah, 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 blah. That's that bloody thing because I normally put my slides up, right? And every word on it tells me what I'm going to say. And he goes, you're allowed 3 words. I'm like, you don't, I've got to memorise it now, right? So our ability, right, to be 8 words. He told me 3. You were winding me up.
Just keep you on your toes.
Yeah, well, there's no words on this one. Do you see that? So our ability to do that will depend upon the degree of pathology present, the degree of abnormality of function, and more importantly, the amount of time that the individual is prepared to commit to a rehab process. When we're running, there is going to be a flight part. So both feet are off the ground. And although it's not the same, it's rather like jumping off the box. And we're going to use this to have an example about how different function can occur. So in our first example, we're going to have a kind of average step length. So the foot lands somewhere in relation to the centre of mass. That whole video is not coming up, but he uses ankle, knee and hip function to dampen load and prepare for propulsion. In our second one, we're going to look more of an excessive step length. So in this instance, when he jumps, we're going to see he's going much further forward. So as a result, he's going to need greater ankle, knee and hip motion. And also there's going to be more control features. He needs better control. In the last one, he's going to land with reduced knee flexion. So now he's not dampening load. And when he lands, what I want you to see, if we can see it, is the shock as it goes up the leg by the movement of his shirt. It doesn't show. You're joking. How's that cut out? Okay, not to worry. So what you basically see there is you see his shirt's doing this because of the vibration that goes straight up the leg because he's not using knee flexion to dampen load. So now when I assess my patient, I think of sagittal pain in terms of how it dampens, attenuates load, and generates power. The control features are frontal and transverse plane motion, and then we have gait parameters such as step length, step width, vertical exertion, and step rate that contribute to function and potentially alter load through the limb. In the 3D system that I use, it gives you discrete values, so the numbers for each measure. It gives you the kinematic curves so that we can look at the shape, but it also compares an individual's values to an uninjured database. So it gives us an idea where each joint functions on the spectrum. So this is an example of an elite runner. He was a sponsored athlete from Saucony and a student scholarship in the States, but hadn't run for 3 years because of recurrent right calf problems, despite extensive evaluation, rehab and PRP therapy. When we assessed him, what became obvious when we look at the hip is that he had a high level of hip flexion but reduced hip extension. So his power generation was poor. Yet on the right side, he's got high knee flexion and a lot of ankle dorsiflexion. And when we look at the curves in a moment, he was basically using his knee and ankle to propel through gait. So our management plan for him, and it was exacerbated by an excessive step length, our management plan for him was to do some rehab around the hip to get him to alter his pelvic and hip position and address his step length. This shows us his baseline, so he's at a higher end here. But what I want you to look is the kinematic curve for dorsiflexion. So this is actually plantar flexion here. The green line shows us toe off, and you can see some asymmetry in the curves. When we look at him post-rehab, he's reduced that step length, and importantly at this point, it's become more symmetrical. Having not run for 3 years, he's recently completed a number of 10Ks, did a 5K in 15 minutes, and about 2 or 3 weeks ago, he ran 83 miles in training in preparation for a marathon for the first time in 3 years. So we got some data that show the change of function as well as the outcome. One of the things we can't manage clinically is rotation, in particular tibial rotation. And given that tibial rotation has been linked to arch height and or rear foot motion, is perhaps one of those missing links. This is actually my daughter. She's got pretty symmetrical underlying structure, but she's got asymmetrical function in that she gets early medial forefoot loading on the left because of poor control around the hip and pelvis. But what you will notice is her reduced tibial rotation. When we take her out of a neutral shoe and put her into a shoe that's got a flexible sole with a flexible upper, we almost reverse the tibial rotation. And although there's a little bit of improvement at the pelvis, it doesn't improve at the hip. And now because the shoe's flexible, that motion from the hips allowing the shoe to deform and the tibia rotates. You'll also notice that she's got increased load beneath both first toes because she's using her hallets to try and stabilise the foot. When we stick her into a shoe that's got a bit of structure into the sole and a moderate degree of rigidity to it, we get the best overall function here. We get a better function in terms of loading. And importantly, she said to me, "Dad, of a range of shoes, that was the most comfortable one." And we know in the literature that comfort in terms of shoes and orthoses is one of the big factors. So what we're perhaps seeing here is that the structure and function of that material of the shoe has optimized her preferred movement pathway. One of the things that we can't do is to measure moments. Okay, so we've got 3D kinematics on its own. Because we're not including the kinetics in it, we can't do joint moments. So we are making an assumption that by changing the kinematics, we're altering load. That would have to be looked at individually. But what we can do is say, well, when we stick some orthoses in, do we push someone further away from an optimum? It's not an optimum position, that's the wrong term. Are they an extreme or are they less extreme? Are they more symmetrical? And this just simple off-the-shelf orthosis is an example that we can do that. However, you don't always get that response. That's why treatment packages have to be individualised. Griff's going to talk more about gait retraining, but the system can allow you to do real-time gait retraining. And this is an example of someone walking whose step length or overstride was almost double. We gave him some hip cues and asked him to shorten. And although it's a busy slide, you can get an opinion or certainly see that things became much more symmetrical and less extreme. One of the problems with any kind of treatment or gait retraining or alteration in load is you do not get rid of the load. You don't get rid of the force, you just transfer the force. So think of the problems that we had when people went to forefoot running. What's quite nice is when we change something, being able to see whether we've changed everything for the better or not. I can tell you now, because we've analysed loads of orthoses, a number of things improve, but a number of things get worse. And in some patients, it just goes all over the place. That can't be right for the patient. So in conclusion, if we think of sagittal plane, power generation and attenuation, frontal plane, control and the various gait parameters, we have a number of factors by which we can either optimise or potentially change the preferred movement pathway. What 3D gait analysis allows us to do is to evaluate those factors, focus our target and assess our outcomes. Thanks.